Good afternoon. Welcome to another edition of McMaster Perspective, taken this time in the beautiful city of Krakow during McMaster International Review Conference in Internal Medicine. This conference has few parts, and I managed to miss one of the most important, which is called Medical Education Forum. However, we have two distinguished guests. One, Professor Brian Garibaldi, who works in Northwestern University in Chicago, and Professor Tim Niessen, who is from Johns Hopkins. They both presented today during the Medical Education Forum, and maybe I will start for my own benefits, gentlemen. Could you tell me what you were talking about there?
Why don't you start, Brian? You gave the first talk.
Sure. Thanks, Tim. So I was talking about strategies to reinvigorate the practice of the bedside clinical exam. So we know that we spend, as trainees in particular, we spend very little time in direct contact with patients. And as a result, fundamental skills that can only be practiced at the bedside are in decline. And this leads to diagnostic error. This leads to a fracturing of the patient-physician relationship. This leads to stress and burnout among providers who don't get as much fulfillment taking care of a digital representation of a patient as they do when they're with real people. But we need to reimagine those skills in the context of technology that's available that we should be using at the bedside. For example, point of care devices like ultrasound and digital stethoscopes, and now emerging AI tools. And we need to be really intentional about how do we combine those new technologies with traditional talk and touch that we know is still effective but is being underutilized.
So if, very frequently I go to the medical floor and I see a central station with 15 computers, which are all occupied, and another 15 rooms where the patients are alone. How to convince people that it's important? What arguments, what kind of evidence you could use to convince people that this balance should be shifting?
So I guess the first piece of evidence that we're actively compiling, but it also exists over the last several years, we know that the ability to take a good history and the ability to observe patients and do a physical exam still impacts the decisions that we make. And when we don't do those things, for example, the most common mistake in the physical exam is simply that the exam was never performed. When we don't do those things, it leads to error. And so what we try to do through the Society of Bedside Medicine and at Northwestern at the Center for Bedside Medicine is we're trying to create experiences that teach people the value of observation skills, that teach people the value of asking the right question and then listening to the answer. And that also teach people the value of incorporating technology, both to calibrate your physical exam skills, but also to gather information that maybe you wouldn't have gotten from your history and physical. But it starts with creating those experiences in the room with patients to really get buy-in from trainees that, hey, if I spent 10 more minutes with a patient and 10 fewer minutes searching for answers on the electronic health record, 99 times out of 100, that 10 minutes spent with the patient is going to be more valuable. But unless we create those intentional experiences, it's really hard to convince people that they're missing out on those opportunities.
Tim, you are both creators or organizers of the Society of Bedside Medicine. What made you to start? What made you to motivate?
Years ago, Brian and I went to a conference over at Stanford focused on clinical skills and bedside medicine. And what was that, 2015, 2014? It was incredibly inspiring to see a group of 300 plus physicians, nurses, residents, and trainees all gathered together to reinvigorate and inspire the mission of bedside medicine. Abraham Burgess and Stephen McGee, fathers of evidence-based medicine. I left that conference wanting to found and establish a whole clinical service dedicated to clinical skills training at Johns Hopkins. And for 2 years, Brian and I ran an entire service dedicated to improving physical diagnosis and clinical reasoning skills for our residents at Hopkins.
Are you successful, you think?
That is an interesting question because, as you said earlier, we observe a really unrelenting trend away from the bedside that has happened year over year. In the talk I gave, one of the things we observed was in the 1970s, Reichman observed about 75% of all clinical teaching happened at the bedside. By 2010, Gonzalo, less than 1% at that institution, right? That feeling that we're moving away from the bedside to the corridor, to the conference room is real and recapitulated in the data. we made great headway from 2016 until 2020 of bringing our learners and trainees back to the bedside. And then what happened? The pandemic happened. And when the pandemic happened, we lost so much ground in what it's like for our mentors, our trainees, the people who trained through the pandemic and are now our attendings. They're much less confident and skilled at teaching at the bedside. So these last 5 years, we have had huge setbacks, I think, in bringing all of us back to the bedside.
You are the leaders of bedside medicine. What can you advise those who drifted away?
It's really important for us to engage, multiple levels of our faculty, of our trainees, of our medical students. Part of what I talked about was adult learning strategies to bring back skills and attitudes that make people not so anxious to come to the bedside, to get out of the conference room and come back. And some of that is, if you have an attending hospitalist new on the floors who has not had the experience of teaching at the bedsides, they don't know what to do. So you need to take them in a safe space and give them a schema, a rubric of how to conduct effective bedside rounds, because that skill and knowledge not everyone has anymore. So it's really basic targeted detailing of our faculty is one basic place to start, where we give them a script. This is how we expect bedside rounds to go well. This is what effective bedside rounding in the hospital in 2025 looks like now.
And do you have a program where you are trying to institute and teach your attendings this kind of skills?
We sure do. We have a couple different mechanisms to achieve that at my hospital. One is a direct peer observation where our hospitalists will go on rounds with their co-hospitalists, not in any mechanism where they're supposed to teach or do anything other than observe and then provide peer feedback of how those rounds went and how they could be improved for our basic junior faculty.
Well, that's obviously incredibly time-consuming, and I suspect you are facing some resistance from that, or enthusiasm.
Time is always precious, right? And we are in an era in which we don't have a lot of additional salary support or funding to promote these sorts of efforts. But many of our junior faculty, they really want to become excellent medical educators. And the way we apportion time to teaching is based on resident review and feedback. So there's a lot of motivation for people to perform well on their rotations, and getting active coaching and feedback helps them do better, to get better resident evaluations, and then to have more teaching time as a consequence. So there are ways to motivate people, even in lean times.
And I think it also is important to recognize the real barriers that people are thinking about in terms of their workflow and their structure. And part of the reason it's so important to choreograph bedside experiences and to give faculty more foundational experiences and doing better at the bedside is, when it's been studied, doing rounds of the bedside is more efficient. You uncover information that you otherwise would have missed. And patients, when they've been asked about it, either like it just as much or like it more than when teams are rounding away from them. But if you don't have that structure in place and you go and spend hours and hours of inefficient time at the bedside because you didn't have a plan, you didn't have choreography, you hadn't done faculty development, it's very easy to lose, particularly trainees who think, well, this is taking away from the work that I have to do. And part of our job, I think, in bedside medicine is reminding people that the work that needs to be done is with the patient in the bed. It's not remote from the patient. And we have to really create those high value experiences where we demonstrate, hey, looking at this person and seeing that the left side of their chest isn't moving the same as their right, that information exists nowhere else other than in the room with this person. And you could spend hours on the electronic health record. You never would have gotten that piece of information.
Well, if I could add from my own experience, we are all critical care physicians, from what I understand, among other things.
I am general internal medicine.
I
I'm the
am
only one
general
who's not
internal
critical
medicine
care
as well, but I work in ICU. And I made a rule that every learner has to touch each of their patients at least once a day. I don't care which part of the body, within reasons, but they have to touch them. And myself, you probably are aware that we moved from goal-directed therapy, oximetric swans, central line, and ended up with capillary refill and feeling the warmth and circulation in the legs. And they all seem to have equal value, except that one takes technology, funds, and time, and the other one you could do within 1 minute. But despite all what you do, the trend is away.
Amazingly, you mentioned physical touch as an important thing. Years ago, when we were doing one of the original time and motion studies at Hopkins, in which we had undergraduate students follow around our interns and observe how they spent their time in real time over their 16-hour shift, we conducted an assessment of what we called etiquette-based communication. Did they introduce themselves? Did they sit? And one of the measures of etiquette-based communication was, did they touch the patient at all? And an overwhelming sad observation was, in a very, very small single-digit percentage of our patient encounters did interns achieve all of these metrics of etiquette-based communication. And in only very minority of cases did our interns make physical contact with patients at all.
Well, I threaten my residents and interns saying that if they don't touch the patient every day, they will fail the rotation. That hopefully worked a little bit. Now, recently, there is so much talk about artificial intelligence. And one of the things which struck me immensely, we always thought, okay, artificial intelligence would be for knowledge translation and trying to figure out the algorithms and so forth. But the human touch is crucial. The human voice, the human interactions. I'm scared a little bit by the reports saying that artificial intelligence may be actually better talking to the patient than people are. Do you have any opinion? Do you know anything about it?
Well, the first thing I would say is that most of the studies that have come out so far looking at that have been simulating typing messages through an electronic patient portal between a standardized patient actor and either a physician or artificial intelligence. So it's not surprising that an AI algorithm that has an unlimited capacity to throw in extra sentences that are, empathetic and don't really necessarily have any intent behind them. It's not surprising that they might do a little bit better on those scoring. But when it comes to actually being in a room with a patient, we know that doing a physical exam and laying on of hands, there's controlled evidence, randomized control trials showing that a physical exam can have a placebo effect if it's done well. It's probably also true that if a physical exam's not done at all or done poorly, it probably has a negative impact on the way that patients value our judgment and our ability to contribute to their healthcare.
Well, there is no question. And when my family member, I heard it so many times, goes to a physician and comes and he or she, they didn't even touch me. They didn't examine me, and they are quite incensed. Maybe it's a generational issue. Maybe, maybe new generation will not expect that from happening.
Well, I do think there's the possibility that as we change the way that we communicate in general in society, so as younger generations spend more time digitally communicating and being remote from each other, the explicit value that people derive maybe from those personal communications might go down a little bit. But we have to remember that we're evolutionarily hardwired to be social organisms, right? And so I think it will still remain valuable to create connection through physical presence, through eye contact, and through touch. And it's going to be hard to replace that, even if it's not something that people on a survey might explicitly say that they value as much as they used to.
Some of my most profound moments with patients haven't involved many words at all. I simply sit in silence and be present at the bedside as we're walking through a difficult diagnosis or bad news that a patient has received. It's not the words necessarily that matter. It's that you're physically there at the bedside with them and experiencing that with them.
You are both practicing in an environment in which you are cognizant of those processes and cognizant of them, of the values of them. What can we advise clinicians who didn't experience that, who do not practice in this environment, and they may be even losing the capacity to recognize that they lost it? How to stimulate people at this stage?
So I think a lot of what we think about is around building community. And so organizations or conferences like MIRSM with the Medical Education Forum, bringing people together from different practice backgrounds, different countries, different cultural belief systems, and sharing what are the things we have in common, trying to understand what those differences are, and then talking about it here. I think that helps us to understand where there might be opportunities to collaborate and to move things forward together. We've had a program through our Society of Bedside Medicine called our Bedside Scholars Program, where every year we give out at least 2 grants for people to do a bedside medicine project at their home institution with their home mentorship, and then our society provides additional guidance. And we've learned so much about how to incorporate technology, how to think about trauma-informed care, how to deploy resources to, underserviced or in places where resources maybe hadn't been available before. And so I really think our main job as a society, or our main goal, is to build that community to understand where those gaps are and how we can help.
When you are talking about it, I mean, you mentioned teaching it in an under-resourced areas, and what I find, especially we are in very multinational meeting here, our colleagues from call it lower income countries, they seem to be quite a bit more in tune with putting hands on the patients and interacting with them, because they don't have one computer per every room, right?
Yeah.
When you teach bedside medicine, do we mean physical examination, or do we mean non-verbal communication or verbal communication, or all of them?
I think it's all of them.
All of it.
And I would even say the word bedside sort of conjures up this picture of, a physician and a patient in a hospital room, but it can be in a clinic room, it can be through telemedicine, it can be in a home, hospital at home situation, an assisted living facility, a nursing home, anytime where there's care being delivered to a patient, no matter where that is, that's bedside medicine. And that care takes the form of nonverbal communication, verbal communication, laying on of hands, and using technology to help us not just get the right answers for patients, but to help them navigate uncertainty. There's a lot of ambiguity in what we do despite all the technology we have. And I think the more we explicitly acknowledge that, the more people are going to be comfortable with these uncertain situations, which include going to the bedside and just having a conversation and seeing what happens. We have to be comfortable with saying, I'm not sure what's happening. This is the process that we're going to use to try to figure it out together. And I don't know what the right answer is, but let's talk about what your value system is and what your preferences are, so together we can navigate that uncertainty. That really, for me, is what bedside medicine is about.
Let me talk a bit about uncertainty, because I learned a bit about you, including your flamenco music and classic guitar playing.
Yeah.
But you are also the director of biocontainment unit, I believe, or something of this kind. And you are on the cutting edge of next pandemic planning. Is that all correct?
So that was my previous role at Johns Hopkins. For 10 years, I directed our Special Pathogen Center, which is one of 13 federally funded centers in the U.S. They originally founded in 2014 to deal with viral hemorrhagic fever outbreaks. And then we had a very important frontline role in caring for the first COVID patients, but then setting up both prospective randomized control trial research as well as retrospective data analysis from the hundreds of thousands of COVID patients that we saw in our Hopkins health system. So that was one of the roles that I left behind when I moved from Hopkins to Northwestern, to really try to focus more of my attention on building a bedside medicine center at Northwestern. That's what we're working on right now.
But let me go back to, because that may be of interest to our listeners. Yeah. Are we prepared for the next pandemic?
Well, I would say that there are some lessons that hopefully we've learned in terms of how to think about what we need to do to be ready for the next pandemic. I think we're more ready than we were in 2019, 2020. We're not as ready as we could be based on the very clear lessons that hopefully we will eventually sort of synthesize and coalesce around regarding our COVID experience. Certainly the need to be more upfront and honest about what we know and what we don't know, the way that we communicate as healthcare professionals and also as health policy researchers and advocates, the way we communicate with the public, especially regarding certainty and uncertainty. I think we had some problems in the pandemic where we weren't as explicit about, hey, we really don't understand what's happening. This is our best recommendation today, but this is very likely going to change as we get more experience, as we take care of more patients.
It's almost like bedside medicine when you talk to patient about uncertainty.
Yeah.
And the question is, are people prepared to accept it? And similarly, I ask you the question, are we prepared for next pandemics? And frankly, who knows? Because we don't know
what the next pandemic
We don't know what next pandemic will throw out at us, obviously. Well, congratulations on everything what you do, I will keep watching with interest the medical education. As you know, we are trying to maintain the stream of bedside teaching and in the daily education. If I can go to you, Neil, for a moment, Tim. I looked at part of the work which you were doing, and you were talking about quality of life among intensive care unit patients, delirium, sleep, pain control, and so forth. This is area of my interest as well. How does it tie with your bedside teaching and your clinical work?
Yeah, very early in my career, I cut my teeth with Dale Needham in our ICU group looking at ICU outcomes work, and delirium was really interesting to me at the time. And I now work at night all the time, so sleep was also really interesting to me. So that very first paper I cut my teeth on was looking at the association between self-reported sleep quality in the intensive care unit and subsequent transitions to delirium.
Among physicians or patients?
Patients. Yeah.
Works both ways, by the way.
That's right. That is part of my life experience now, because I flip-flop back and forth between the night work and the day work regularly. So there's just papers out now looking at the increased risk of mortality amongst dedicated night shift workers, 12% increased risk in mortality for all of us, including you, Brian, now that you work shift work at night sometimes too. But focused on the kinds of issues that come into the hospital at night and how to bring bedside medicine education in the night hospital is really interesting to me now. That's a long way away from delirium and critically ill patients for me now, but it's such an under-resourced and unexamined area of the hospital. No one knows what happens in their hospitals at night, except for the very few of us who work there. And our interns still do like extended duty hour call. They do 28-hour calls every 3 to 4 nights. And what kind of education or experience they have is really a black box to most of our programmatic leadership. I think that is a very ripe area to explore how we can bring people back to the bedside in the night when we're not confronted with as many pulls in different directions, because there's more bandwidth and more time in the night hospital than there is during the day.
Well, one thing which strikes me, I remember the, again, conjunction between critical care and the rest of the hospital, that mortality of people who are transferred from intensive care during after hour is actually close to twice the mortality of people who are transferred during the working hours. So this part of sleep and delirium, which we all experience, is fairly crucial. You mentioned a few times about incorporation of today's technology into bedside teaching. You mentioned ultrasound use, which becomes ubiquitous these days. People start to use it. Any other technological advances which we could suggest to people?
You know, for many in bedside medicine community, we look with disdain at use of portable or mobile devices at the bedside. It's requires a lot of pre-education for patients to understand that, hey, many of us are going to have devices, but it's such an undervalued and underappreciated ability to bring the entire medical record to bear with you in your hand. Like Epic is on your tablet. You have every test, every note that's ever been written about the patient in your fingertips. And on top of that, we were talking about artificial intelligence. Many of my learners, they are not looking at Facebook or Twitter or X, or whatever other social media stream. They're actively looking up using, things like open evidence, what is an appropriate differential? What are the next questions I should ask? What are the next steps in diagnosis and management I should be thinking through to help advance the care of
Maybe
this
that's
patient?
the part of communication requirement to tell the patient, that's what I'm doing now, rather than...
It's become part of my introductory script when I'm talking to patients about what to expect on bedside rounds. Hey, most of the people in the room are going to have their phone, and then they're going to be looking at your medical record in real time as we're going through the case presentation. So we really all know the entire universe of data about you and your care.
So maybe that's the part, moving from the computer station and the central station of the floor to patient's room, except that you have all the data which you need there, including all communications with your consultants and so forth.
Yeah, and it gets back to the efficiency issue, right? If we all have access to the history and physical that the overnight admitting doctor wrote, we don't have to recapitulate that entire thing at the bedside. We can spend that time gathering additional information which we wish we had. We can spend that time engaging in shared decision making. And that allows us to be much more efficient and effective with the limited time that we do have. But we need to be intentional about it. You know, I'm glad that the first tool Tim mentioned, like technology-based tool, was the EHR, because we need to be much more intentional about the way we train ourselves and our learners how to use the EHR. Just like we have a hypothesis-driven approach to the physical exam maneuvers that we all use at the bedside, we should have a hypothesis-driven approach to how we approach the EHR, because you could sit down, or the electronic health record.
Health record. EMR, electronic medical record.
Yeah, there's so much information there. You could easily spend 3 hours looking through that.
The
before
amount
you meet the
of
patient.
information may be overwhelming, because I'm calling it regurgitation these days, because people, first person writes something and the next person copies and the next person, it's in the end, it's a double-edged sword as well.
What I try to teach our learners is that the information that you want might be in the electronic health record, but it's definitely going to be in the room with the patient and their family members and their loved ones. And if you start there and then approach the electronic health record as a supplemental source of information, what labs do I want to look for? What previous diagnostic studies should I look for based on why this person's presenting to the clinic or hospital now? It becomes a much more efficient tool, as opposed to something that takes up all of our time and all of our focus.
Well, my conclusion from it is where I started, which is to teach younger physicians or trainees to touch their patients every day. That's my own mantra. I wonder what you would share as the last words with our listeners.
I would say that our goal is to build community around bedside medicine, and to remember that our goal of our job is to help our patients navigate, hopefully, their journey from illness to health. But if they're not going to get healthy because they have a chronic condition, then helping them navigate the uncertainty that goes with it. And that starts with being present with our patients at the bedside.
Taking care of the patient with the patient is the mission of bedside medicine, and we all should be there.
Thank you very much. I really appreciate your thoughts, and I hope there will be some use of it for people to listen to it and reflect on their own practice. Thank you.
Thank you
so
Ron.
much.